And it's my big pleasure to introduce to you Tristan Day Margetson first. For those who paid attention, she also gave a talk yesterday. She's from Stanford University in California, and she will talk to us about the use of the TransMedics organ care system in pediatric heart transplants. Thank you, Tristan.
Good morning. I like to see everybody bright and early. I appreciate everybody coming. Also, I want to thank Richard and Carla for inviting us to talk a little bit today about our experience and our advances in heart transplantation. So I just wanted to start this talk to see who is using the TransMedics organ care system, the OCS. Can I show of hands? Okay, right. So not that many of us are using it. It's really interesting. I'm glad to see that, because when I first saw the technology, it's really a fun machine to see. And the first time we put it in our OR, we had about 50 people crammed in there trying to get in to see the heart in the box and what it looked like. So the only disclosure I have is that I was trained on the TransMedics organ care system. I'm going to call it OCS from here on out. That's what I'll be talking about. And that involved, Stanford decided they were going to try to use it. And so they sent two of us. I was the first one that got to go back to Boston to the lab. And it was a great 2 days. They took a pig and from beginning to end showed us how the organs are harvested, how everything works. And we got to sort of study it. And on the way home, we were really excited. And we landed and they said, oh, we've decided to just use the TransMedics system where we call them, their team goes out, harvests the organs and comes back. In the end, I think that was probably a really good decision, because it was going to be hard to stay competent. If you only do this once a year, then you have 8 perfusionists and you're maybe seeing it once every few years. And it was actually quite a bit more complicated than I thought it was going to be to monitor it and to keep everything safe. And I didn't want to be the one to bring back the heart and say, oh, we've opened up this child and now because of Tristan, the lactates got too high. And so it was actually kind of a good thing. No additional disclosures. So today I want to sort of introduce the system and review how it works so that you can see it. And then I want to tell you about what we did differently. So Stanford adults were kind of the pioneers of this technique to do continuous warm blood perfusion through this. And we used it on one of our pediatric patients. And in doing so, we sort of learned a lot of lessons along the way. So I wanted to share those. And then I wanted to show you what's happening in the Stanford lab. So I'm sure you're aware that getting an organ for a pediatric patient is extremely challenging. Right now we have 9 patients under the age of 2 on VAD support at Stanford. They are so cute. They're like sitting up in their high chairs with their VADs, but they're all vying for the same organ, every single one of them. We had 10, and we had one that had been on support for over a year. He was transplanted 2 weeks ago, which was really exciting. He just made the cutoff for ABOI incompatible transplants. So any one of these 9 patients, the next one on the list will get the organ regardless of what their blood type is. We can do an ABOI to replace that, but they're all trying to get the same organ. So one of the reasons why it's challenging is because we use the traditional method of standard preservation for heart transplant patients, and that involves cold storage, cross-clamping, and giving cardioplegia. At Stanford, we also use the Sherpa pack. I'm not sure if people have seen that too. It's an advancement in how you store through cold storage. It's like a little igloo, and it has a temperature monitor that keeps the temperature really consistent inside the pack versus what we used to do, which is like a beer cooler full of ice, and then we put the heart in there. So we've had some success with that, and we're looking at our data on whether that's a better way to do cold storage. But in any event, each time you're cross-clamping and giving cardioplegia, this leads to a lot of ischemic injury, as well as having a lot of geographic constraints, i.e. we can only go 4 hours away for 4-hour ischemic time to get those hearts, including travel time. So this really limits the number of organs we can give to those patients in an already restricted population. Enter the TransMedics organ care system, or OCS. So this offers sort of a promising alternative to what our traditional storage has been. It's fully portable. If you haven't seen it, it's wider than a balloon pump, but shorter. So it's, maybe this big. And what it does is once you put the heart on there, you have to cross clamp it to get it on there, but it mimics the heart's natural physiology, and the heart beats all the way back to the recipient institution. It uses normothermic perfusion to do that. It also minimizes the total ischemic time, and it expands your donor pool. So you can go further to harvest your organs, and you can have more of a long cross clamp time because for part of that, it's beating. The other thing that it can do, and I'm excited to hear talks later this week, it helps with the donation after cardiac death. So you have another patient population you can tap into. One of the limitations that we have in the pediatric population is its size. We'll talk a little bit about that. So there are three main components to the OCS system. We're just going to go over those. The first is the heart console itself. So this is your hardware. It has an integrated perfusion pump that's pulsatile, and it consists of the batteries that get you for where you need to go. It has a warmer. It measures both your pressures and your flows, your SVO2 and your hematocrit. Then you have the perfusion set, so that's the disposable. It's a single use. It measures pressure and temperature, and it has the perfusion circuit and the sampling ports. In case you're interested in knowing how much that disposable set costs, it's about $80,000 just for the set. And finally, they have their heart solution, and this I understand is extremely important. It's their own blend, so it's their proprietary blend for heart preservation solution, as well as their priming and their maintenance solutions. So this is sort of the process of what you do and how you get there. The first is that you need to collect donor blood from the donor heart. Then you're going to prime the OCS system with the donor's own blood. Then the surgeon is going to harvest the organ. You're going to cross clamp and harvest the organ. They're going to cannulate it onto the OCS system. They're going to provide that with the instrumentation, and then finally stabilize it and get it ready for transport. So we sacrificed a pig during our lab, so I got to see how everything was collected. And one of the really important things is that you need to have a high enough hematocrit from the donor to make sure that you can get on the system safely. And I thought, well, why can't you just prime it up with a unit of donor blood? But that would damage the donor heart, so you have to ensure that you make sure that you would transfuse your patient, your donor patient first, let it mix, correct everything, and then drain out the blood. You give the donor patient a systemic heparinization bolus, anywhere from 10 to 30,000 units of heparin. And you use a 40 French malleable cannula in the SVC to put the patient in Trendelenburg and then drain out all the blood. So the reason that's important is because 40 French is a big cannula. So when you're thinking about what size patient you can do, these are really more adult size patients that are pediatrics. You collect 1,200 to 1,500 with another 10,000 in a bag, and then you use that blood to prime the OCS system and to DR everything. If you don't have enough volume from your donor, they're not a candidate for the OCS. Oh, I like this picture. Okay, so this is how the surgeon cannulates and places this on the machine itself. So the first thing they're going to do is cross clamp and give a liter of Plege. Okay, so they're going to arrest the heart. From that point, you harvest the heart and place it on the OCS system. I thought there would be drainage, traditional drainage like SVC, IVC, but they actually ligate those, and the drainage comes out of the PA system. So you're going to drain from the PA as well as placing a passive LA vent. So it's not connected to an additional roller pump, but it just comes out as the heart beats, and they collect that also into the chamber. The blood's returned. As you can see, there's like a little collet nut that looks like at the top. So the surgeon will cannulate the tip of the aorta and secure it with some pledgets and some tie bands, and then they screw that collet nut into the OCS system itself. So here, this is sort of the flow of how things go. We're going to start at the blue line, the pulmonary artery line, and follow it around. So they're constantly measuring through the whole transport what the SVO2 is, and then it goes into the reservoir. And I think I was really worried that the plane would tip or there wouldn't be enough volume, but the way that the chamber is designed, there's enough volume at the bottom not to worry about the reservoir running dry throughout the transport. So it comes out of the reservoir, goes through the pump, through an oxygenator with gas exchange, goes through a warmer, and then returns back into that collet nut that we looked at for the aorta. At the same time, there's an offshoot that's measuring both what the root pressure is and then what the flow is. And the flow is around 700 milliliters a minute to make sure that the coronaries are being perfused at all times. So this is a video that I shot when we were in our lab, and I just thought it was so amazing at the time, but it's a pig heart, and it had been on the system a couple of days, and the TransMedics rep was really nervous. He was like, don't take that. It's going to look like a, non-decompressed heart. And I was like, well, it's just to show what it does, but we'll take a look at it here. Okay, the sound's not working, but it's just us laughing and getting excited because we could touch it. And see, here we go. We're all excited to touch it. So actually, this shot is kind of important because you can see it looks like there's saran wrap on the outside. So there's a hard shell cover that closes. You can see off to the left a little bit over it for transport. And then there's this protective sterile layer. And when it's time for implantation, the surgeon will open that layer up, will pull that back, and then everything inside that chamber is sterile. So after a successful transport, what we're really looking at to monitor, they run blood gases and serial lactates. And we're just really wanting to make sure that the heart's been perfused the whole time it's been on the system. So you're looking for lactates that are less than 5. So once the surgeon gets to the recipient institution and the surgeon decides to accept the donor organ, then she's gonna, first we cross-clamp and give another liter of pledge, but first she's gonna close the LA vent, disconnect the PA drainage cannula, clamp the aortic line, and give another liter of pledge. So now we've had 2 cross-clamp time periods, both with cold storage. But you've had all that time in between on transport with nice warm blood being given, so you are hopefully perfusing the heart. But you have another traditional cross-clamp and pledge. So let's talk about what we did differently and how it worked. So we had a 24-year-old patient with Danon disease, and that manifests itself. It's an X-linked disorder with cardiomyopathy and a skeletal myopathy and some intellectual disability. And this patient also had non-obstructive hypertrophic cardiomyopathy. He also was a Wolff-Parkinson-White syndrome, and he had sort of severe LV dysfunction, and he had a transplant 3 years prior to us seeing him again. Unfortunately, he showed up with heart failure secondary to graft versus host coronary disease, so he needed a retransplantation. So due to the fact that the donor that we identified for him was too far away, we ended up deciding he was a candidate for the OCS transport. So we set up our bypass circuit in the usual fashion, and I was thinking about Keith in this because we usually don't set up a cardioplegia system, and of course, in typical Stanford fashion, the surgeon comes in and is like, I want to do this today. So you have to think on the fly. The perfusionist that did this case is here, Mr. Don Sheff. And of course, he has over 40 years experience. So he was the perfect guy to pump this case and get ready and sort of figure it out. Our cardioplegia system has a bridge in it. So we were able to put it in quickly and then prime it up just with Normasol before the case started. But we were ready to give continuous blood perfusion, which was the surgeon's plan. So the idea was that instead of giving that second dose of pledge, we were going to keep the heart beating while they implanted it by giving continuous warm blood perfusion. So the way that it worked, and I'll show you a schematic of this too, but blood was pulled from the bypass circuit after the oxygenator, pushed through the heat exchanger, the cardioplegia system, and into a 14-gauge cardioplegia needle that was inserted into the aortic root of the donor heart. We kept that at a consistent 34 degrees, so it was just like giving a hot shot, but a continuous hot shot while they were giving, implanting the heart. We didn't really know what we wanted to flow on that. We decided to flow 300 milliliters per minute and just make sure that the root pressure was at least less than 300 at all times. We did this for about 62 minutes while they were sewing the heart in before releasing the cross clamp. I think in future times we might want to measure the root pressure a little bit more seriously than what we did because we couldn't really tell what we were doing. We were just going by the numbers. So this shows you just a schematic of how the blood was flowing. So from the bypass circuit, through our pledge roller, into the pledge system, and then back to the donor heart while it was still in the TransMedics system. In the picture on the right, you can see that our surgeon has cannulated. That's our pledge system coming off the field, and he's already cannulated it and is working on it in the TransMedics system. Now, while this is happening, all of the blood that is coming out through the coronaries is going right back into the TransMedics system. So that's one of the things we learned. I think we sort of dilly-dallied and we were losing volume from our bypass reservoir, and we weren't going to get that back because you cannot scavenge the blood or return it from the TransMedics system. Once we brought it onto the field, we got it together a little bit quicker, and we put pump suckers into the bowl and into the field, so all that blood that was being spilled out, we could scavenge back to the system. But you can see here, we returned it via suckers to our reservoir. It goes through the post-bypass, goes through the roller pump, and then back. So that was our loop. So this patient, after we took the cross clamp off, we just followed what we usually do for our institution, which was reperfusion for at least 60 minutes. He came right off pump, no problem whatsoever. He was extubated post-op day 1, and he was out of the hospital 2 weeks later, which is pretty impressive considering his degree of reoperation and how serious things had gone. So we were very happy with these results. We were so happy, we decided to try it on every patient that we could, and here's what we learned about that. The first thing is that you needed more preparation time. It's not a good practice, not best practice, to come in and say, oh, we're going to try this on the fly today. So we identified the patients that we were going to do. We did another cardiomyopathy patient, and then we tried it once on our Fontan patient. And I'll tell you what happened with that. So one thing is that we learned to scavenge the blood more readily and quickly. So as soon as he transitioned, instead of letting it sit there in the OCS system for a little while, he got it off and then put it back into the field so we could get that blood back much quicker. But we had a Fontan patient that we decided to try this in. And one of the problems with Fontan physiology is the development of a lot of AP collaterals. So you have very sick patient that comes to you and a lot of return coming back to the heart, and you don't know exactly where or when that's happening. And although we vented this Fontan patient, I pumped the case, so I can tell you a lot about it, but I remember everything looked very normal at the time. There wasn't a ton of vent return. It felt like a normal case, and we were excited. We were employing this technique. And after we took the cross clamp off, there was just no heart function. And in retrospect, when we got together to talk about why we thought this was, the surgeon really felt like he hadn't decompressed the heart. He took a lot of ownership over this, and he said, I just don't think the Fontan patients are the right candidate for this procedure. So now I wanted to share with you a little bit about what we're doing in the Stanford lab. So again, the big limitation for the system in the pediatric population is size. So we can't put a 40 malleable cannula in a patient that's 10 kilos or less. So we really wanted to think outside the box, or in the box in this case, and figure out how we could do this for our pediatric patients as well. So one of our goals, so we wanted to create something that was cost effective, that you could take back to your own institution and you could use whatever system you're using. Here you can see we're using the CardioHelp. At Stanford, we have like every system you would want to use. We use the Spectrum pump for our ECMO. We have CardioHelp for transport. We have Centromax. We could have designed anything, but for this lab, we decided to try the CardioHelp because it was the most user-friendly. We felt like there would be less interaction. We cut the lines down, and here you can see that we've also used a CDI and hemoconcentrator, and we'll talk about why we did that and what we think is going to happen. But here's a little video of watching our little system go. Pig hearts. The one thing we also learned about pig hearts are you need a hemoconcentrator because their blood gets dilute very quickly, and we needed enough oxygen, and we don't have donor blood available for our pigs. Doesn't that gas look good? This is showing the system, and it also shows you the monitoring capabilities. So we took a look at what the pressure flow, obviously we monitored the EKG the whole time. Both the OCS system and this system that we're working on, you need to have the capability to pace at all times. So you can see that's happening inside the chamber as well. So this is a little bit of a busy schematic, but this is how we designed it as well. And we'll start here at the venous line. So again, we use the PA for cannulation, and it drains into our collection reservoir. One of the things we learned on the very first trial was we had the blood coming down, but we didn't have a defoamer, and you couldn't believe the amount of air that were happening. So we ended up breaking apart an ECMO oxygenator and using the defoamer components in that to develop this so we could at least get through the labs. So anyway, it drains into the reservoir, through the venous line, through whatever system you might choose. Again, we had the CardioHelp going at this time. And then through the oxygenator, pumped around, through the defoamers, and back in through a graft that we sewed onto the aorta that we could then perfuse and cannulate. We have the pacing system set up so that we can do that, as well as our data acquisition, which include what we were flowing, what the pressures were. Also, we had a level sensor in there to make sure we didn't drain out. So this is just some of our early results on what we found. So we were shooting to mimic, at least see if we could do this, similar to what the OCS system was. So we did 6 hours of beating and perfusion on the hearts. We were flowing pretty high considering what the size of the pig heart was, and I think that's something we'll look at in the future. But again, we were flowing anywhere from 400 to 700 milliliters a minute. And that's what we did. We flow 700 on the adult heart. So you can see we were sort of on the higher end of things considering that the heart was about this big. But then we looked at what the arterial pressures were, what the temperatures were, and then we looked at echoes, serial echoes during and post to see what we had. So starting on the left-hand side, we looked at the lactate levels. And again, we wanted the lactate to be less than 5. You can see here with our pig 1, 2, and 3, we got better as each lab went on. So our first pig is in red, and his lactate still stayed below 5 for that entire 6 hours. Pig 2, we did a little bit better at 4, and by pig 3, we kind of drilled down and figured out what we needed to do, and we had even better results with a lactate of less than 3 for those 6 hours. On the right, you can see what happened to our potassiums. Same thing, they dropped as we went on and as we perfused longer, showing that we weren't having hemolysis and that we were doing our job of perfusing. This was one of our, I just put this in because it's cool. So this is one of our shots of when we were figuring out how we want to actually suspend the heart in the chamber. So we were trying to look at ergonomically and what's going to cause the least amount of damage to the heart, whether we suspend it or whether we're going to lay it down in a chamber. But this is what we've done so far. And it's just, you know, holding this pig heart up in the air, having the vent cannula and having the aortic return. One thing I wanted to mention is that the vent cannula, we put it on a roller head. So instead of being a passive drainage, we did an active drainage. And I think that's going to make a huge difference in the results of how things are going. So we're excited about that development too. I sort of want to try it on the Spectrum system because I can easily mount another small 4-inch roller on that to go. So that's something we're thinking about as well. And this is just a final shot of what it looks like. Let's talk about that CDI one time before I sign off. And that's, we wanted to measure those values so we could see it during the lab. But if we were actually transporting a patient, we wouldn't put that in, nor would we put the hemoconcentrator in. These were just mostly to maintain the lab values and so we could see what we were doing. But I think for transport, you would do what you normally do, which are run lactates and run gases on a portable way, because this would be more cumbersome to take. So that's another reason the Spectrum system might be nice to have as well. All right, that's it. Thanks.